Good day to all of you. So I hope you all are actually staying at your home very safely, and at the same time I hope you will be utilizing your time very usefully and in a productive way. So today I am going to discuss about the prostate gland and the seminal vesicle. So both the prostate gland and the seminal vesicle are actually accessory male reproductive organs, or you can call it as the sex glands, male sex glands. So first we will move on to the learning objectives for today. So we will have a short introduction about the prostate gland, then its situation and measurements, coverings, the capsule of the gland. Then followed by that we will try to understand the various parts, presenting parts of the gland, relations, various surfaces, then how the gland is divided into lobes. So whether they are particularly divided in any fashion or they are arbitrarily divided. Then blood supply, nerve supply, lymphatic drainage. Then the structure of the prostate gland, how the various structures within the prostate gland they are dispersed, or any other structures which are piercing the prostate gland and opening into it. Age changes. Finally, we will conclude this chapter with the clinical aspects. Now coming to the prostate gland, with a short introduction. So I already mentioned you, it is actually an accessory male reproductive organ, and it is also a fibromusculoglandular organ. So it has got fibers. So mainly fibrous stroma is present there. Muscle fibers is also there, and mostly it is the smooth muscle fibers. It is also believed some striated muscle is also present there within the prostate. And I told you it is an accessory sex gland. And what is the main function of the prostate? It adds volume to the semen. So the seminal fluid, it's actually secreted by the secretions. Its secretions, they are the secretions of the prostate, and also they are secretions of the seminal vesicle. Of course, throughout the tract, as they pass through the epididymis, also secretes certain fluids. All these adds to the semen, and the secretions of the prostate mainly consists of acid phosphatase. So acid phosphatase, and it also contains fibrinolysin. Prostaglandins. Prostaglandins are actually considered as local hormones. The name prostaglandins, the term is coined because these prostaglandins were first detected in the secretions of the prostate. So all these mainly aid in the transport of sperm in the female genital tract. Okay, so fibrinolysin, as I told, acid, phosphatase, and all those things, they have anti-spermiophagic actions. So they protect the sperm from being phagocytized. Not only that, they also aid in the contraction of the smooth muscle of the female genital tract so that the sperm is transported. They also contain a large amount of zinc. So zinc is actually anti-spermiophagic in action. So homologous to paraurethral glands of the female. Okay. So the same, if you look, the synonymous glands in females, they are actually paraurethral glands, which are situated on either side of the urethra, in the membranous part of the urethra. And in males, actually it is a male organ, the prostate gland, which surrounds the commencement of the male urethra. So that is why the proximal part of the urethra itself is called as the prostatic part of urethra. So urethra we have just discussed in the last class along with the urinary bladder. So both the male urethra and the female urethra. So male urethra is very long, and the first part is actually the prostatic part. Then we have the membranous part of urethra, and then you have the penile part, which is the longest part in male urethra and which is absent in the females. So it is called as the penile part of urethra or the spongy urethra. So where actually this prostate gland is situated? It is situated in the lesser pelvis. So by this time you know what is lesser pelvis and what is greater pelvis. Lesser pelvis is the true pelvis, which includes the pelvic cavity, which is present or limited above by the pelvic inlet and below by the pelvic outlet. So in the lesser pelvis, it is situated immediately below the neck of the bladder and behind the pubic symphysis. So behind the pubic symphysis and below the neck of the bladder, it is situated, and it is resting on top of this membrane or urogenital diaphragm. Okay, so it rests on the urogenital diaphragm. So the urogenital diaphragm is mainly made up of two muscles, sphincter urethrae and deep transverse perineum. These two muscles are covered by a fascia above and a fascia below. So above fascia is called a superior layer of urogenital diaphragm, and this is actually called as the inferior layer of urogenital diaphragm. So these two muscles are actually covered by fascia above and below, and this diaphragm is pierced by the urethra, which is called as the membranous part of urethra. Okay, in males as well as females, the membranous part of urethra pierces this urogenital diaphragm. So it rests, the prostate gland, the apex rests on the urogenital diaphragm. Behind the pubic symphysis, it is situated in the lesser pelvis and below the neck of the bladder and in front of the rectal ampulla. So behind you actually can appreciate or you can find the rectal ampulla. Ampulla of rectum is the lower dilated part of the rectum. So anywhere you come across the term ampulla means it is dilated. Ampulla of vas deferens. You have ampulla of the fallopian tube. So measurements, it is chestnut shaped. People call it, actually it is usually described as a chestnut shape, and the transverse diameter, the breadth is more than the length. So which is 4 centimeters breadth and 3 centimeters length. One of the organ where the breadth is more than the length. So one more example for such type of organ is your cecum. So your cecum, again the breadth is more compared to the length, and it weighs around 8 grams and 2 centimeters in thickness. So that is about the gross morphology of the prostate gland. So next, very important aspect of the prostate gland is the coverings. It has a true capsule and a false capsule. So true capsule is fibrous condensation. So it is nothing but the condensation of the fibrous stroma. So fibrous stroma, what happens is thickly invests the gland, and from the deeper surface it sends numerous fibrous septa. So thereby dividing the gland into many lobules. Okay. False capsule is actually derived from the visceral layer of pelvic fascia. So pelvic fascia will line the wall of your pelvis. So your lateral wall is bony wall, which is also muscular because your levator ani muscle, piriformis, coccygeus, all those muscles also take origin from the lateral and posterior wall of the pelvis, and they will be covered by a fascia which is the parietal layer of pelvic fascia. That parietal layer, what happens? It will reflect as the visceral layer. It will reflect as the visceral layer on the various viscera of the pelvic cavity, your urinary bladder and prostate in males, and only the bladder in case of males, and uterus, and also the lower part of the rectum. They have reflected onto this as the visceral layer of pelvic fascia. So this visceral layer, what happens is, it is continuous with the false capsule of the urinary bladder. Okay, so this false capsule of the prostate, which is derived from the visceral layer of pelvic fascia, is continuous with the false capsule of the urinary bladder above. Okay, below it will blend with the urogenital diaphragm. Okay, so this part you are able to see here, urogenital diaphragm, which is mainly formed by the sphincter urethrae, this muscle fibers, sphincter urethrae. So they will merge with the fascia of the urogenital, superior fascia of urogenital diaphragm below. Posteriorly, it will merge with the fascia which is called as the rectovesicular fascia of Denon biliaris. Okay, so posteriorly it will merge. So you are able to see this as septa. That septa is mainly formed by the rectovesicular fascia. The rectovesicular fascia is the primitive rectovesicular pouch. It's a primitive pouch which has fused and which is given to this thick septum, and the permanent rectovesicular pouch you are able to see here. So it is the first formed one which has fused. It is called as the rectovesicular fascia. Okay, and that is posteriorly. Anteriorly, what happens is the false capsule is attached to the pubic symphysis as the medial and lateral puboprostatic ligaments. Okay, so medial and lateral puboprostatic ligaments anteriorly, and posteriorly it merges with the rectovesicular fascia of the Denon biliaris. So that is the various modifications of the false capsule of the prostate gland. Now between the true capsule and the false capsule, so the true capsule, you won't be able to separate the true capsule because it tightly invests the gland, and that is your false capsule. Between the true capsule and the false capsule, you see the prostatic plexus of veins. Okay, so the prostatic plexus of veins are present between the true and the false capsule. So that is very important clinically as well as surgically, because during prostatectomy, when the gland has to be removed, total removal, total prostatectomy, you remove the gland leaving the capsule. So you don't remove the true or the false capsule, because if you try to incise the capsule, then naturally the prostatic plexus of veins might rupture, causing an alarming hemorrhage. Okay, and not only that, the prostatic plexus of veins also plays a major role. It is the route of spread of metastasis from the prostate gland. So cancers of the prostate through the prostatic plexus of veins can actually spread to the other areas. So I will come to it later while dealing with the venous drainage of the prostate gland. So I just want to mention here or stress here the fact of the capsule, that is the true capsule and the false capsule with respect to the prostate gland. So coming to the presenting parts, so it has a base and an apex. So base is the upper broad part which you are able to see, and the apex is directed below and resting on the urogenital diaphragm. Then it has got an anterior surface, posterior surface, and two lateral surfaces. On either side you have the two lateral surface, and then you have an anterior and a posterior surface. So four surfaces, one apex and a base. So base is the broad part and surrounds the neck of the bladder. So it actually surrounds the neck of the bladder, the base. It is pierced by the urethra, not exactly at the middle, but at the junction of anterior 1/3 and posterior 2/3. So you are able to see behind the urethra, posterior 2/3 of the gland is present. Anterior 1/3 only has been removed to show the urethra, which is passing inside the prostate. prostatic part of urethra. Okay, so base is actually pierced by the commencement of the urethra at the junction of anterior 2/3 and posterior 1/3. So apex is lower part which is resting on the urogenital diaphragm. Okay, so that is your urogenital diaphragm. Apex is resting on the urogenital diaphragm, the upper surface. The upper surface of urogenital diaphragm has a fascia covering it, and just little bit in front of the apex, slightly anterior to the apex, the urethra pierces. Okay, so this part is actually the apex. Just in front of the apex, so to be precise, on the anterior surface, the urethra comes out of the prostate gland. So urethra pierces the gland just in front of the apex. But usually we imagine that the urethra will just from the base it will start and come out of the apex. No, just in front of the apex, and we are able to see the urethra is traversing the gland at junction of anterior 1/3 and posterior 2/3. So it is not exactly in the middle. Okay, it is not in the middle, but in the midline. Middle and midline are different. Okay, so midline is, so you just make two halves of the gland anterior-posteriorly, then you can see the urethra in the midline. Okay. So we finished about the apex and about the base. So base is the upper part which is surrounding the neck of the bladder, and the apex is the lower part, pointed part which is resting on the urogenital diaphragm, and it is directed downwards. So anterior surface, of course, this you are able to see the posterior surface. The bladder they have just turned to view the posterior surface. Anterior surface, it will be related to the pubic symphysis, and between the gland and the pubic symphysis, you have the retropubic fat or retropubic space filled with the retropubic fat, and you see the prostatic plexus of veins in the retropubic space, and also these plexus of veins receives the deep dorsal vein of the penis. Okay, so between the prostate, anteriorly the surface, anterior surface is related to the pubic symphysis. Between the symphysis and the anterior surface, you have the retropubic space filled with retropubic fat and deep dorsal vein of penis and prostatic plexus of veins. So that is about the anterior surface. So urethra actually pierces this surface in front of the apex, which I have already mentioned to you in the last slide. So next, coming to the posterior surface. So the posterior surface is broad and flat. It's somewhat flattened from above downwards, and it is also very broad, and it is related to this ampulla of the rectum. You are able to see the lower dilated part of the rectum is actually called as the ampulla of the rectum. It is separated, so the posterior surface is separated from the ampulla of the rectum by the retrovesicular fascia, which I already told you. This fascia gets inserted into the perineal body below. So what is intervening between the ampulla of rectum and the posterior surface of the prostate is the rectovesicular fascia. So the posterior surface, when you look at it from behind, so this is the posterior view where the rectum, anal canal, and the other muscles of the posterior wall of the pelvis has been removed. So now you are viewing the posterior part of the bladder, mainly the base of the bladder with the seminal vesicle and the vas deferens. Below that, you are able to see the prostate gland, and this is a levator ani muscle forming the pelvic diaphragm. Okay, and that should be the superior fascia of urogenital diaphragm, and that should be your inferior fascia of urogenital diaphragm. And between these two, you will have the deep transverse perineum. So this muscle is your deep transverse perineum, and one more muscle surrounding it is the sphincter urethrae. So a very beautiful diagram, rather I would say, because in anatomy, I again repeatedly stress the importance of the diagrams, because picture speaks. A single picture speaks 1,000 words, rather than you go on explaining to pages. So if you look at this picture, you just concentrate and look at the picture for at least a couple of minutes, and if you are able to imbibe in your mind, you are just able to memorize the picture, which is rather easy, very easy to actually remember the picture rather than remembering all these text matter. So if the picture unfolds in front of your mind in your examination hall, then easily you can write. You have an orientation of the structures, what is present in the front or behind, or its relations, extent, everything can be easily recollected. So I again advise you to actually try to visualize as many pictures and also practice diagrams. That is very, very important, and that is what through my lectures also what I would like to stress is I am providing many pictures as much as possible, quality pictures which are actually easy to understand, at the same time appropriate and correct pictures which gives most of the details. So that is why so many pictures I usually try to incorporate into my presentations. So I am in one way making your job easy, so that you need not go and hunt for pictures or search in the net. That job is also made easy, and it is spoon fed to you. So one resource where everything is available. So the posterior surface is divided by a transverse groove into an upper transverse groove. It is divided by a transverse groove into an upper part, which is actually the median lobe, and the lower part is again divided by a vertical groove into two lateral lobes. Okay, and along this transverse groove on either side, it is pierced by the ejaculatory ducts. So posterior surface is flattened, broad and flat, and it is related to the ampulla of rectum. You see a transverse groove which divides the upper small part and lower large part, and that lower part is again divided by a vertical groove into two lateral lobes. So this posterior surface can also be palpated through the rectal examination. So again, the clinical aspects I will come back to it with respect to the rectal examination, and you are able to see the lateral surface is actually related to the levator ani muscle. So that is the levator ani muscle, which is mainly forming your pelvic diaphragm. Coming to the lobes of the prostate. So anatomically only three lobes, one median lobe and two lateral lobes. Classification of the prostate into lobes is one median lobe and two lateral lobes, but surgically surgeons actually they describe five lobes, one median lobe, one anterior, one posterior and two lateral lobes. So the division is actually arbitrary. So both the views are actually correct. So we will try to understand in the surgical point of view with respect to these lobes. So median lobe here you are able to see is wedge shaped, base again directed downwards, apex directed downwards, and base forms the uvula vesicae. So the base actually is related to the trigone, apex of the trigone of the bladder, and forms a small elevation which is called as the uvula vesicae. Base. Apex is actually towards the colliculus seminalis. Apex of the lobe points towards the colliculus seminalis, which is again a raised fold you can see on the posterior wall of the prostatic part of urethra, colliculus seminalis. In front, it is related to the prostatic part of urethra. So this is your base related to the prostatic part of urethra in the front. Above forms the uvula vesicae, apex colliculus seminalis, and on either side you have this ejaculatory ducts. So this side ejaculatory duct, on the opposite side. So on either side you have the ejaculatory duct. This ejaculatory duct is actually the combination of the seminal vesicle, duct of seminal vesicle, and the ductus deferens. Both have a common duct which is called as ejaculatory duct, which opens into the prostatic part of urethra. Okay, so that is the boundaries of the median lobe of the prostate. Okay, ejaculatory duct on either side, in the midline by the prostatic utricle, and in front by the front, and in the middle anteriorly and to the front is by the prostatic part of urethra. Lateral lobes are seen on either side of the prostatic part of urethra or lateral to the ejaculatory ducts. So on either side of the urethra, and what happens is they actually have a partition only superficially, these lateral lobes, but posteriorly both the lateral lobes are continuous with each other on either side of the urethra, and that continuation of the lateral lobes behind the urethra is considered as the posterior lobe by the surgeons. So that is how the posterior lobe is actually classified with respect to the surgically. So continuation of the lateral lobes behind the urethra at a deeper plane, only superficially both the lateral lobes are separated by a groove or septum, but the septum does not continue into the internal aspect. So both the lateral lobes are connected by what is called as the posterior lobe. So you are able to see that is the urethra or the urethral crust, two lateral lobes, continuity of the lateral lobe is the posterior lobe. The two lateral lobes are also continued anteriorly, which is also considered as the isthmus. It is mostly fibromuscular, and in children up to 6 years of age, this lobe or this part contains mucous gland. So any part which has a glands can be considered as a lobe. So that is how anterior lobe is classified. So lateral lobes and one. This is the median lobe, but anterior and posterior lobe. So anterior lobe are connected in front of urethra by the fibromuscular isthmus. So in the children, it contains mainly the glands. That is mainly mucous glands. Okay. So that is the demarcation of the prostate gland into various lobes. Now structures within the prostate, so mainly it is pierced by the prostatic part of urethra. Okay, so mainly pierced by the prostatic part of urethra, extends from the base and slightly in front of the apex, the anterior surface. The whole length is actually traversed at the junction of anterior 1/3 and the posterior 2/3. Then one of the other structures piercing is the ejaculatory duct, which you are able to see here. So the ejaculatory duct, as I told you, is a combination of the seminal vesicle and the vas deferens. Pass posterolateral to the median lobe. So median lobe posterolaterally is bounded by the ejaculatory duct on one side and the ejaculatory duct on the opposite side. Okay, so these two form the posterolateral boundaries, ejaculatory ducts. So here you are able to see the two ejaculatory ducts on either side of the median lobe. So they are opening into the prostatic part of urethra. So then this small sac, what we say is the prostatic utricle. So a cul-de-sac or a blind sac. Okay, so a blind sac behind in the midline you will see, which is called as the prostatic part of which is called as the prostatic utricle. So all these we have already discussed in the urethra, male urethra. So cul-de-sac which opens into the colliculus seminalis. This mainly your prostatic utricle is the remnant of para-mesonephric duct, and it is also considered as the male vagina. Then numerous openings you are able to see around, in front and behind the urethra. They are actually called as the prostatic sinuses, through which the glands of the prostate open into the prostatic part of urethra. Okay. So prostatic sinuses are minute openings which you can see at the level of colliculus seminalis and also above and below the colliculus seminalis. So this, the posterior wall of the prostatic part of urethra you are seeing, which shows an elevation called as the colliculus seminalis. It is pierced in the midline by the prostatic utricle, which is a cul-de-sac, I told you, remnant of para-mesonephric duct. And on either side you are able to see that is the ejaculatory, opening of the ejaculatory ducts. So above the level of colliculus, at the level of colliculus and below the level of colliculus, you see numerous small minute openings. They are the prostatic sinuses. So the secretions of the prostate are poured into the prostatic part of urethra through these prostatic sinuses. So now coming to the internal structure of the prostate, which is essential to understand the function of the prostate. So mainly fibrous part. Fibrous part, fibrous stroma condensation, which forms a true capsule. This fibrous stroma, what happens is it also sends septa. It also sends septa, and thereby what happens, divides the gland into many lobules. Okay, there is also an internal capsule which I will come to it later. Muscular part is present in 3 layers. One is the outer layer, which is continuous with the detrusor muscle of the bladder, outer longitudinal, continuous with the detrusor muscle of the bladder. Then you have an inner layer or middle layer, you can consider as middle layer around the urethra, surrounds completely, which is considered as the middle layer. There is also one more layer just in front of the urethra. Just in front of the urethra, there is also one more layer of muscle fibers. They are considered as the striated muscle. Now, between the outer layer and the middle layer, muscle fibers also radiate. They also radiate between the outer longitudinal layer and the inner layer. They also radiate. Now, what happens is the contraction of these muscles helps to pour the secretions of the prostate gland into the prostatic urethra. At the same time, they dilate the prostatic urethra. So they compress the prostate gland and dilate the prostatic urethra. So the secretions are poured into the urethra. So mainly during ejaculation. Okay. So it has got a fibrous part, and then it has got a muscular part which is present in 3 concentric layers. Now, between this outer fibrous part and the muscular layer, you can see the glands are actually arranged again into 3 zones. Innermost glands, then you have intermediate glands, and then you have the outermost main principal glands. The innermost glands surrounds the urethra. They are mucus glands. So they are simple tubular glands, and you see they don't show any follicular pattern. They are just mucus glands. Okay. So they open into the prostatic sinuses above the colliculus seminalis. The next glands is actually the submucous glands. The submucous glands, they show mild outgrowths or follicular pattern. Okay. And what happens is they are externally surrounded by another capsule which is actually called as the internal capsule. They are actually called as the internal capsule. Now these two, the mucous glands, are mainly present in the children, and after puberty what happens is the outer main principal glands, they develop. Until then they are rudimentary. These main principal prostatic glands you can see with the numerous follicles, outer main glands with numerous follicles and long ducts. They open via the prostatic sinuses below the colliculus seminalis, whereas submucous glands opens exactly at the level of colliculus seminalis. Now the inner mucous and submucous glands, they are under the influence of estrogen. So if this part, there is a benign hypertrophy of this gland, fibrous stroma part especially, then for them what happens is they are given testosterone to suppress the growth of this inner part. And not only that, the inner capsule acts as a guide to the surgeon to enucleate this part of the gland, that is the benign hypertrophy of the gland, okay, fibrous part of the gland. Outer main glands are actually under the influence of testosterone. So mainly in carcinoma affects these outer main glands, and since they are under the testosterone, sometimes estrogen is given to suppress these growth of these glands. Okay, so the outer glands are mainly, as I told, enlarged in case of the prostatic carcinoma. So between the outer glands and the mucus and submucous, as I told you, there is a capsule. This is called as the internal capsule. Blood supply is mainly supplied by inferior vesicular arteries, prostatic branch of inferior vesicular artery, which you are able to see here, and then middle rectal and internal prudental arteries. So you are able to see the internal prudental arteries and the middle rectal arteries. They all give a branch to the prostate. So these actually pierce the prostate and form two plexus. Immediately beneath the capsule, they form subcapsular plexus, and one more capsule is the periurethral around the urethra. Two plexus they are formed. So these branches are mainly inferior vesicle, middle rectal and internal prudental are branches from the internal iliac artery. Coming to the venous drainage, which is comparatively very important than the blood supply. So they are drained by prostatic plexus of veins. Okay. So prostatic plexus of veins, which is present between the true and the false capsule. These plexus of veins are continuous above with the vesicular venous plexus. So they communicate with the vesicular venous plexus, and in front it receives the deep dorsal vein of the penis. So it receives the deep dorsal vein of the penis, and ultimately it drains into the internal iliac vein. Now, in front of the sacrum, you have anterior sacral foramina, through which certain veins, what happens from the prostatic venous of plexus, they communicate to the vertebral venous plexus, which is present inside the vertebral column, internal vertebral venous plexus. So these veins which communicate with the prostatic plexus and internal vertebral venous plexus are called as paravertebral veins of Batson. So they mainly pass through the posterior two ligaments of the bladder. They are called as the paravertebral veins of Batson. And this communication, what happens is, in increased intra-abdominal pressure, like during coughing or straining or sneezing or constipation, reverse flow of blood takes place, and these veins are all valveless. Plexus of veins are valveless. Reverse flow of blood takes place, and because of that, secondary spread of cancer, metastasis of prostatic carcinoma can easily spread to the vertebra. So from there it might spread to the central nervous system also. So metastasis from prostate to vertebra and brain mainly through this paravertebral veins of Batson. So lymphatics mainly to internal iliac nodes, external and sacral nodes. Sympathetics from L1, L2 segments of the spinal cord to superior hypogastric plexus. Mainly they are vasomotor and pain sensations. Carry the pain. Parasympathetics, sacral outflow, S2, S3, S4, pelvis splanchnic nerves. So they are mainly secretomotor, parasympathetic nerves. Coming to the age changes, so at birth, very small in size, only the duct is present, you don't see numerous follicular or glandular material. Mucous glands, you can see simple tubular glands. Sudden spurt of growth takes place at puberty. So at puberty, what happens is, numerous follicles tend to grow, especially on the outer zone, and the size almost increases, it's double the size at birth, and as I told you, rapid growth of follicles and fibrous stroma gets condensed. After 45 years of age, these mucous folds will disappear, and you can see the follicles are filled with corpora amylaceae. Okay, corpora amylaceae. When you come across, then naturally it should be the prostate of a middle-aged man. At old age, two extremes might occur. It might get atrophy, mainly because of the declining testosterone levels, or it might become benign hypertrophy. So the fibromuscular stroma might enlarge. The inner part of the gland might enlarge, forming benign hypertrophy at the old age. So mainly enlarged middle lobe, especially benign hypertrophy, or inflammation of the prostate, prostatitis, might be due to so many reasons, bacterial infections or urinary tract infections. Anything might also affect the prostate gland. So in benign hypertrophy, the median lobe might enlarge, uvula vesicae, and might might actually compress or block the internal urethral opening. There, because of that, urine retention. So urine retention is difficulty in passing the urine. So urine is getting blocked inside the bladder, not able to evacuate completely, and the more pressure is given to actually micturate, this acts like a ball valve, and the more it will compress. Okay, so that is mainly the benign hypertrophy of the prostate. Prostatic carcinoma, so mainly affects the outer part, the main glands, and prostate specific antigen. So mainly screening is done whether for the presence of prostate specific antigen. Prostatectomy might be total prostatectomy, where you just leave the capsule and enucleate the gland, or partial prostatectomy can also be done. Mainly two routes, one is suprapubic route and other one is the transurethral resection of prostate, which is called as the TURP. Transurethral resection of the prostate is called as the TURP, and this is the most preferred method. So through this, what happens is the inner mucus and submucous part is removed. This part is present deep to the internal capsule, okay, in benign hypertrophy of the prostate. So in total prostatectomy also, what happens is the gland is removed with the capsule left intact. So this is actually per rectal examination in males. So you can actually palpate the posterior part of the prostate, the median lobe, whether it is enlarged or not, and of course the seminal vesicles, vas deferens, posterior part of prostate gland, perineal body. So all those things can actually palpated through per rectal examination. Okay. Per rectal examination of the prostate. So we will just quickly look into the seminal vesicle, again a necessary reproductive gland, which is situated lateral to the ampulla of vas deferens. Situated lateral to the ampulla of vas deferens, in close association with the base of the urinary bladder, and it is sandwiched between the bladder in the front and the rectum behind. So secretions mainly forms the bulk of the semen. So seminal vesicle secretions mainly form the bulk of the semen, mainly consists of fructose, nutrition required for the semen to survive in the female reproductive tract, and it also contains prostaglandins. So prostaglandins and the fructose are the main constituents of the secretions of the seminal vesicle. So it is situated to the base of the urinary bladder. Relations, so anteriorly base of bladder, posteriorly it is related to the ampulla of rectum behind, and medially vas deferens, the ampulla of vas deferens, the terminal part of the vas deferens. Posterior two ligaments of the bladder, actually lateral relation. So blood supply is again the inferior vesicle, middle rectal, corresponding veins, drained to internal iliac veins, again L1 to L2 hypogastric plexus, superior hypogastric plexus, parasympathetic is S2, S3, S4 pelvis planktonic nerves. So there are paired ducts, it unites with the terminal part of the vas deferens to form the ejaculatory duct, which opens into the prostatic part of urethra. Okay, and opens to the prostatic part of the urethra at the level of colliculus seminalis, through which the secretions are actually poured. So it is a single duct. If you look at the seminal vesicle, single duct which shows numerous diverticula, and it is lined by simple columnar epithelium. Okay, highly coiled, numerous diverticula. You can see a single duct which is highly coiled and lined by simple columnar epithelium. And based on the activity of the gland, which stage the gland is, the height of the epithelium differs. So that is all about for today. Thank you very much for your patient listening.